Well, good morning, everyone. My name is Doug Poland, and I'm a partner at the law firm of Stafford Rosenbaum and chair of the DMI Board of Directors. Thank you for joining us for our virtual November What's Up Downtown breakfast. For this morning's event, we are pleased to welcome Rick Ransom, Regional Vice President and President of UW Hospitals Madison Region, to provide a UW Health and Pandemic Response update. Before we start this morning's program, I would like to take just a minute to update you about some of the positive things that are happening downtown. I know that the temperature is getting colder, the hours of sunlight are getting shorter, and with the COVID pandemic constantly in the news, it can feel like we are in a bleak position as we head into the winter. But despite the challenges, there are some encouraging developments downtown, and I want to highlight just a few. First, the Common Council approved ULI's American Exchange project this week. That's a project that could bring up to 2,000 new office workers to the square downtown. The Common Council also approved LZ's 148-unit apartment project on the 400 block of East Washington Avenue. That's a project that will help connect the Capitol East District to the square and will add more housing downtown. The council approved the Business Improvement District's 2021 operating plan and continue the city's commitment to fund programming downtown in an amount of $65,000. There was acceptance of the federal community-based crime reduction grant. That's $1 million over 3 years. And it's an innovative community-based multidisciplinary project and effort to reduce crime downtown, focusing on root cause issues. There is increased funding for street homeless outreach programs downtown through Catalyst for Change. There's continued work of the downtown group task forces to make downtown a more equitable and vibrant place for everyone. And something I know that we've all been longing to see for a long time, the boards that have been covering up storefronts downtown are being removed throughout the entire downtown, including at the Overture Center. In sum, there are many reasons to take pride in and be bullish in our downtown. Cities go through periods of ups and downs, and right now, Madison is not alone in experiencing challenges that we never have faced before. But the same aspects, characteristics, and spirit that have made Madison a great city, and one that we all love enough to make it our home, will still be here when we emerge from the current crises. And more than anything, it is the people that make a city truly great and that transform a place from just another city into a true community. So let's support each other, our friends and neighbors, and our downtown community, and rededicate ourselves to working through these challenges together. Before we continue with the program, I would like to thank all of our sponsors of today's event. Thank you to major series sponsor Wipfli LLP, supporting series sponsors Ho-Chunk Gaming Madison, Michael Best and Friedrich, and State Bank of Cross Plains, and special contributors, the Edgewater Hotel and UW Health, Unity Point Health Meritor, and Quartz for their support of DMI in downtown Madison. I'd also like to thank Capital Bank for participating as our monthly sponsor. We greatly appreciate Capital Bank for their support of today's program and would like to welcome Amy Guile-Engie, Vice President of Mortgage Lending at Capital Bank, to briefly say a few words. Amy will be followed by Anita Mohammed, representing Wipfli LLP and DMI Treasurer, and then followed by DMI President Jason Ilstrup to introduce this morning's speaker. Thank you and welcome, Amy.
Good morning, everyone. I'm Amy Guile-Engie, VP of Mortgage Lending at Capital Bank. We're honored to be this month's sponsor, and I'd like to take a few minutes to introduce Capital Bank to those of you who may not be familiar with us. Capital Bank has grown from a few employees and $5 million in capital in 1995 to 60 employees and $480 million in assets today. Our success and growth is built on making a difference in this community. Amongst our 60 employees, we hold over 30 positions on local boards and committees. And just last month, we donated $25,000 to area nonprofits in celebration of our 25th anniversary. Our tenured employees have a wealth of expertise and market knowledge, which allows us to make decisions with local focus. While we have a wide variety of personal and business banking services, we are known for our mortgage lending, commercial lending, and business banking. I'd also like to take a moment to mention my gratitude for UW Health and American Family Children's Hospital. Several of Capital Bank's employees have been involved in these organizations. Some employees, myself included, have experienced the great work UW Health is doing firsthand. My son Brady, now a sophomore in college, was born with congenital heart defects and had open heart surgery at 5 days old. In the last 20 years, all our experiences with the healthcare professionals at UW Health have been exceptional. If you're interested in learning more about Capital Bank, visit our website or follow us on LinkedIn. Thank you.
Good morning. My name is Anita Mohammed, and I'm a partner with Whipley LLP and member of the DMI Board of Directors. Whipley is pleased to participate as the major sponsor of the DMI What's Up Downtown Breakfast Series. Thank you for joining us this morning. As a multidisciplinary professional services firm, Whipley delivers effective, personalized services to help companies and organizations like yours through these trying times to help create lasting positive impact. We are here to help leaders like you navigate the ever-changing economic environment, and we invite you to visit whipley.com for industry-specific insights for financial institutions, construction and real estate, nonprofits, and more. Thank you for joining today's program, and I hope you are all safe and well.
Good morning, everyone. Welcome to another virtual What's Up Downtown Breakfast, where we bring everyone together to hear more about what's happening in the community. First of all, hope you're all doing well and hope you're all staying healthy. Thank you very much for joining us today for a very important conversation with Rick Ransom from UW Health. I want to first say thank you, Doug, for your continued leadership and all of our board members who give so much time to our organization. We really are thankful. Thank you, Doug. Thank you also for the update. Lots of positive things are happening downtown right now. Thank you to Anita and the team at Whipley for your continued sponsorship of this program and the entire organization of DMI. We would not be able to do it without you. And thank you so much, Amy, and everyone at Capital Bank for all you've done for years for downtown and for all of our community. Thank you so much again to Doug, to Anita, and to Amy. It is absolutely my pleasure to welcome Rick Ransom here today to have a conversation about UW Health and their pandemic response. Rick Ransom is the Regional Vice President and President of UW Hospital's Madison region, where he provides the direction for the American Family Children's Hospital, UW Health at the America Center, and the university's hospital. He also provides primary oversight of the joint operating agreement with Unity Point Health, Meritor, and multiple clinics, programs, and services. Since 2014, he has served in a variety of leadership roles with the Greenville Health System in Greenville, South Carolina. Most recently, the Chief Operating Officer at Greenville Memorial Hospital. Prior to joining the Greenville Health System, Rick had multiple leadership roles at Baptist Memorial Healthcare Corporation in Memphis, Tennessee, including Executive Director of Oncology and Director of Business Development and Assistant Administrator. Rick has a Juris Doctorate from Stanford University, Cumberland School of Law, and a Master's of Science in Health Administration and an MBA from the University of Alabama at Birmingham, and he received his Bachelor's of Arts from Morehouse College. Good morning, Rick. How are you doing this morning? Hope you and your family are doing well.
Good morning, Jason. Good morning, all.
We're excited to hear your presentation, and the floor is yours.
Thank you very much. So I'm going to begin by navigating Zoom and sharing my screen. And
we can see it great, Rick.
Okay. All right, excellent. So Jason, thank you very much for the warm introduction. As you mentioned, I've spent some time in the South. I am originally from Birmingham, Alabama. It's interesting that, I'm the son of a physician. So my dad is an ED doc, and I've got a younger brother who is a physician in Atlanta. And, being first a lawyer and then a hospital administrator, I've actually been the black sheep of the family. So my dad calls me his two-time loser. And whenever people talk about my educational background, I kind of hear my dad's voice in the background. Thank you to DMI for the opportunity to talk to you this morning a little bit about COVID-19, its impact in Madison, how UW Health has responded. I want to bring to you greetings and thanks on behalf of the nurses, physicians, and frontline staff members that are working at Unity Point Health Meriter, UW Health locations, the UW Health Rehab Hospital. We do appreciate the support of you all as business and community leaders throughout the course of the pandemic. I also want to bring to you greetings from Dr. Alan Kaplan and the leadership team at UW Health. And then finally, I want to thank our leaders with DMI for arranging this opportunity to engage this morning, for facilitating the discussion. So Madeline, Doug, Amy, Jason, thank you for your leadership and for making this discussion possible. As I was looking at the roster of participants, I did see some familiar faces. So I've been here about 2 years. I actually started in December of 2018, and I saw some familiar names. And for those of you all that I have not seen since really the pandemic began in earnest, you may notice that I am scruffier. So, you know, for the last 10 years, I've shaved my head completely. And the running joke has been that, like a lot of other people, I have pandemic hair. I have been telling my youngest daughter, who's a freshman at Wanakee High School, that I've been working on my man bun and my mullet. And I think that's probably overly optimistic. I was sharing that with my 16-year-old son. And he said, well, based on what I've seen with granddads and other Ransom men's hair, this is probably the farewell tour for your hairline. So I wanted to just mention that in addition to this presentation, you're also getting a chance to participate in the farewell tour for what hair still remains on my head. All right, so with a few what I hope to be humorous notes to kick us off, let's go ahead and jump into the body of the presentation. And my intent this morning is to try to cover 3 major areas. So the first is the arrival of COVID-19 in Wisconsin, how it has impacted UW Health and our incident command response. I also want to talk a little bit about some of the changes that have been brought about because of COVID-19. So in some ways, COVID-19 has been a catalyst for a lot of change, and quite a bit of it is positive. And so in terms of change, innovation, and our response, there's some things that are probably the silver lining based on COVID-19's impact here. And then finally, although my crystal ball is frequently fuzzy, I do want to share some insight into what I believe the road ahead looks like for us here in Wisconsin, in Dane County, in the upcoming weeks and months. So let's first talk a little bit about COVID-19 and its arrival in the US and the beginning of calendar year 2020. And to do that, there are a couple of things that I think are important to understand in terms of context. So the first is that January 2020 is what I would describe as a typically challenging environment for hospitals at UW Health, Wisconsin, and most of the country. So hospitals and clinics, we were busy. One of the things about Dane County providers is that, you know, we tend to stay pretty busy, tend to stay pretty full. You know, with any winter, any respiratory season, staffing shortages, so people will call out because of colds and flu, et cetera. For us in Dane County, the challenge of how is it that we grow to meet the community need? So thinking a little bit about infrastructure needs and how is it that we evolve to meet the needs of patients going forward? And then finally, how do you pay for it all, right? So as you think about, all right, what was it that hospitals were grappling with in January of 2020? These were 4 of the things that I think were on a lot of people's minds. And then we have the arrival of COVID-19. So the article here that we screenshotted is from February the 5th of 2020. So the news reports about the first patient at UW Health were in early February, late January. And it's important, again, as part of the overall context, for me to highlight a couple of things that have gotten different between February of 2020 and today when we're having this discussion on November the 18th. So the first thing that has evolved or changed has been our knowledge about the disease, COVID-19. So specifically, how it's transmitted? How do you prevent transmission? When people have COVID-19, how does it progress? What are the treatment options? So one of the things that has improved and gotten different from February till today, but that was a factor early on in the response, is our knowledge about the disease COVID-19. Excuse me. A second major difference where we've seen some improvement and some change has been in the availability of personal protective equipment and essential supplies. So if you think about a lot of the news reports and stories and discussion and energy around securing N95 masks, I dare say that most people participating on this call this morning understands what an N95 is. And my suspicion is very few had to understand what an N95 was back in December, of last year. So being able to identify barrier masks, gloves, sanitizer, N95 masks, PAPRs, all of the things that we need in order to care for infectious patients safely, there have been real challenges around the availability of the supplies that are needed to care for COVID patients. So thing number one, where we've seen some improvement, has been in our understanding of the disease. Thing number two that has evolved or improved has been the availability of critical supplies. And the third thing that has really evolved and improved over time has been our access to diagnostic testing so that we can detect COVID-19 in patients and members of the community and in our staff. So it's important to understand that at that time, we didn't know a heck of a lot. And so as we go through the rest of the presentation, I just want you to keep in mind that all three of those things are evolving as we look at the response, our actions, and where we are now. So the picture here is from a training session at UW Health for our HICS, or Incident Command Structure. And the acronym Hospital Incident Command System, HICS, is one that describes the standardized structure that hospitals like UW Health and across the country use to manage any adverse incident or event. So HICS has, the structure itself has been around in some form since the 1980s. The catalyst for it becoming really standard, kind of the de facto way that hospitals respond to a community event, really was advanced by 911. So there was an analysis that was done after 911 that looked at, all right, how did communities respond? And one of the things that it detected was that there was a lack of standard approach. So HICS really became more and more the standard way that hospitals and health systems manage through events after 911. And it does present several advantages. So the first of those is it has clearly defined roles and responsibilities. And at some level, clearly defined roles, to those of you all depending on your industry or your business, that may sound like, well, why wasn't that already being done? The challenge that EMS providers experienced prior to HICS becoming standard was they were subject to the mercy of individual organizations and their org charts, right? So at UW Health, the titling may be a little bit different than it is at St. Mary's. And St. Mary's may be a little bit different than it is at ProHealth. And ProHealth, the titling may be a little bit different. In addition to just titling differences, at St. Mary's, they may want their CEO to be the incident leader, to be leading the response. At another organization, they may want the COO to be the leader of the response. So just figuring out in an event, whether it's a weather event or an attack or a spill of some sort, who do you talk to? Who's in charge is a big problem that first responders had to wrestle with. So clearly defined standard roles and responsibilities is one of the defining characteristics of the incident command structure. What you see here and the people with the blue vest in the picture, those are the standard roles. So on the back of each one of those blue vests, they've got their role. So the gentleman who's furthest to the left in the picture with the blue vest is Dennis Maher. He is a VP of support services and is responsible for our supply chain, among other things. He's serving as incident commander, and that's printed on the back of his vest. So everyone in this training exercise has on their blue vest, and we are modeling different scenarios around what incident command, how we're going to respond to a particular event. This room is where we began our COVID-19 incident response. So although this is a picture from a training exercise, we were in this room, it looked like this. It also looked like this in some other ways. So we didn't have on masks. We didn't, like the spacing wasn't ideal. And when you think back to what we knew about COVID-19 and how we were managing through the event, one of the things that's evolved is from this moment in time to today, we do most of our incident command virtually. So I think we're at a point where 90+% of our incident command meetings are done via WebEx or virtual meeting. There's very little of people being in the same room to manage through different components of our response. So Hicks, this picture, how we began with in-person. We were in one of the rooms over at the American Family Children's Hospital to today is one of those things that I think graphically illustrates how our response has changed as our knowledge has improved. Emergency management systems in hospitals also have pretty consistent components. There's some key parts to everybody's emergency management system that I think I want to highlight for the group. So one of those is there has to be an oversight group, a committee or a team. It is multidisciplinary. It is so people who have expertise in security, in medical equipment management, in facilities or engineering, people that come from different medical backgrounds. So there'll be an emergency room physician that'll be a part of it, or a critical care doctor, nurses from different locations. So different sites, different disciplines that is charged with oversight of the health system's emergency management program. They do planning, develop mitigation tactics. They coordinate with external agencies. We do training for staff, drills. When we need stuff, whether it's communication devices or vest or whatever it is, identifying resource needs, and then reviewing the overall effectiveness of our program. So part of what we do inside the emergency management structure is grade ourselves on how we've been able to prepare, how we responded to either drills or actual activations. I want to go over a few milestones in the first 5 months or so of our COVID-19 response to just kind of emphasize how things started and how things have unfolded. So, you go to January 2020 when news of the coronavirus first broke nationally. The treatment then in early February, late January of the first COVID patient at UH. The activation of the UW Health Incident Command structure. So we moved what we call a level 3 activation, which is not everybody in their blue vest, but some key members of the command staff and other support staff. We moved from a level 3 activation to a level 1 in early March of 2020. Travel guidance around quarantining and sheltering in place. We put in measures to try to conserve PPE. Guidelines and restrictions on visitation is one of the things that also came about in March. One of the things that I'll talk a little bit about more in some subsequent slides is we also made a big investment, a big shift in providing care virtually. So we rapidly expanded our ability to provide telehealth in March, and the way Dr. Tom Brazelton, who's been really involved with our telehealth program, he described it as we made 10 years worth of progress in 10 days. So the shift that we made to be able to provide more care remotely is something that we really pushed to do in March. March and April is also when we began to reduce, quote unquote, elective surgeries and procedures. So one of the things that I'll talk some more about is, what we did with reducing surgical procedures and elective cases and what the impact has been for the health system, but we really began that in March and April. The financial impact, of turning down the volume with surgical procedures, we began some cost control measures to try to make sure we were able to sustain operations and sustain the health of the health system in April as well. So other visitor restrictions. May is when we were able to offer antibody testing available to the community. There are three of these things that I want to spend a little bit of time on. So the first is visitor restrictions, and that is one that has been heart-wrenching, tragic. There are stories in the media. It is one of the most difficult aspects of our COVID-19 response. And for someplace like, for all of our hospitals, and particularly for someplace like UH, which tends to have the sickest patients, to not be able to have a loved one be with you when you're going through your care and treatment has been one of the most difficult things to decide to do, and also to try to manage through with community members and patients. The second thing that I want to talk about, which has been a big part of our overall response, has been the consolidation of some of our ambulatory clinic operations and kind of what has gone into those decisions. So this idea that when you've got 7 hospitals, 90 plus ambulatory sites, how is it that you decide what stays open, what closes? And there are a couple of different factors that really went into the UW Health approach. So one of those is really, really pragmatic, and that is the availability of staff. So as you look at some of the smaller, physician offices where you may just have 5 or 6 team members, 1 or 2 people being out with the flu or being redeployed to work in another area can be really disruptive to the care that's being provided. So for smaller sites, the availability of staff, are we going to have enough people to sustain operations at this location for an extended period? So availability of staff is one of those factors. The nature of COVID-19 and the fact that it is something that really has respiratory symptoms, being able to cohort respiratory patients by site. Right? So as you think about, all right, how is it that you maximize the safety of COVID patients, non-COVID patients, and the team members that care for them, having an approach where you're able to get respiratory patients to all go to one location is one of those factors in, all right, what needs to remain open, what services are we providing in different locations. And then finally, the third factor that's made a big impact in the clinic sites that have been opened and those that have had their hours adjusted has been the impact of remote work and telehealth. So when you look at how much care was being provided in person versus remotely pre-pandemic versus today, big changes. In addition, a lot of the work that used to require team members to be physically present in a clinic can be done remotely. So those things have affected, all right, well, what is the core staffing required to service patients at different locations? The third other impact, the third other thing that I wanted to emphasize was around the impact of surgeries and procedures being postponed. And, as I thought a little bit about, all right, how is it that you describe that to folks who have varying degrees of familiarity with, what goes on in hospitals, this idea that there are really kind of 4 different ways that you can end up in a hospital bed. There are 4 doors to get to an inpatient bed inside a hospital. The first of those doors is the emergency room. And for people who are ill and they come to the emergency room for treatment, a percentage of those people that walk into the ED or get brought via ambulance or personal vehicle end up getting admitted. Depending on the hospital that you work at and how sick the patients are, I've seen anywhere from 5% of those patients get admitted to 35% of those patients get admitted. But one way, the main way that people end up getting it into a hospital bed is through the ED. The second door that leads to an inpatient admission is transfers from other hospitals. And for places that have a lot of subspecialists that provides kind of niche care, the number of patients that get referred from other hospitals, get transferred from other hospitals can be significant. So door number one is the ED. Door number two is transfers from other hospitals. Door number three is direct admissions from physician offices and urgent care centers. So let's say that Jason went to go see his primary care physician, and his doc saw something that he was concerned about, and he decided that Jason needed to be admitted. He could call from the office, and provided he had admitting privileges at the hospital, directly admit Jason to a bed there. Right? So door number three is direct admission. Sometimes that comes from private doctors in their offices, sometimes also from urgent care centers. Door number four is the one that I want to emphasize here, and that's the surgical and procedural schedule. So a certain percentage of patients that are getting surgeries and procedures like catheterizations or electrophysiology procedures end up needing to stay overnight. In those cases, a lot of them can be scheduled. So as you think about, all right, there are these four doors, four ways you can get to an inpatient bed. The first three of them, really hard to predict at a micro level. You can say over time, we're going to get 34% of people that come to the ED will get admitted at University Hospital, which is actually probably not that far off. So you can talk about macro level aggregate statistics, but to try to really control the number of people that get admitted to inpatient beds, the lever that's most effective is around that surgical and elective procedure schedule. One of the challenges of our response has been communication. And if you think a little bit about the Hicks structure or the Hicks concept, the idea that you've got this command staff that is really responsible for making the decisions that will guide the organization's response. For UW Health, for Meriter, for St. Mary's, for other large hospitals or health systems, communicating, like there's what you do, and then there's how do you tell people, how do you inform all of these folks in different settings about what the decision was and what the course of action needs to be. So our approach at UW Health was to try to have a single source of truth for both internal team members and also for the public. We have had a public information officer. So one of those people in blue vests is a public information officer, and that person rotates. They have a team that is devoted to trying to make sure that command staff decisions get communicated quickly and effectively. And that group has been working incredibly hard since the very early days of the pandemic. I would be remiss if I didn't take this moment to give a shout out to some of those folks and just recognize them. Chris Roth, Tom Russell, Allison Rowe, Terry Shore, others. The charming and vivacious Julie Aulick has served in a different role. Shiva, the legend, has also been a part of the command staff. So the work that those folks have done to coordinate with community partners as part of our response and to manage communications has really been phenomenal. Part of our messaging strategy has included daily public and media messages. So this is video and written content. We felt a responsibility as part of our mission as an academic medical center, as part of our mission as a safety net provider, to try to provide accurate information throughout the course of the response. We developed a new website, and we have had our UW Health experts really open to participating in interviews. So at its height, we've had as many as 20 interviews done with some of our physician scientists. This idea that we also feel a responsibility to get accurate information, to correct misinformation where there may be confusion, and to try to promote the overall community's health throughout the course of the pandemic. So two people whose faces may be familiar to you under this umbrella are Dr. Jeff Potoff and Dr. Nasia Safdar. So Dr. Potoff is an amazing and very cool guy. So my hope is that you guys will have an opportunity to maybe meet and talk to him if you haven't already. Jeff and I served in incident command to begin with. And in the early days of the UW Health response, when we were still working out some nuances of our structure, he and I served for the first 3 weeks. So I don't know who was Pancho and who was Cisco or who was Batman and who was Robin, but he and I rode side by side for the first 3 weeks of our incident command activation. And my appreciation for what he brings, what he can do, and what a great person he is has just grown since then. So Jeff is an ED doc. And in addition to, and I teased him mercilessly about all of the interviewing, if you have an opportunity to meet him, call him Doc Hollywood. He loves it when you call him Doc Hollywood. Jeff he takes shifts in the emergency department. He's on the flight team for MedFlight. So there are days where he is taking a shift in the emergency department, coming back up to work in incident command, and then doing media interviews. Dr. Safdar the same way. So her specialty is infectious disease. She still cares for patients. She's been on MSNBC. I can't remember if it was Jeff or Nasia that was on the Today Show. This idea, though, that they are leading physician scientists, not just here in Dane County, but nationally and internationally. And one of the great pleasures of my tenure here has been able to work with them and to collaborate with them. So let's talk a little bit about the impact of COVID-19 and how it's been a catalyst for some innovation and some change. So in Scientific American in October, there was an article that indicated that COVID-19 has become the third leading cause of death in the US, behind heart disease and cancer. One of the things that has been a feature of our planning efforts and our response in late spring and early summer was this recognition that heart disease and cancer didn't take a break when COVID-19 came to the US. So for us, our mission is to provide remarkable health care. This idea that we have an obligation to continue to care for the cancer patient, to continue to care for the stroke patient. And in order to do that effectively, we have to have the ability to care for both COVID patients and non-COVID patients. So I've described this perhaps a little bit crudely, that our exercise in planning and preparedness has been a bit of a two-step. So we have been trying to maintain the capability to care for the cancer patient, the heart disease patient, et cetera, and have the ability to increase our capacity progressively to care for COVID-19 patients as the situation requires. So things like routine colonoscopies were activities that we had to put on pause early in the pandemic in order to create capacity. The exercise now is not stopping that. It's how do we continue that and also care for COVID patients. Things like bringing treatments for convalescent plasma and other things to the care of COVID patients have been things that we've learned, things that we've adapted to, and things that we're able to do going forward. A couple of areas that have received a lot of media attention lately are the clinical trials around the AstraZeneca vaccine, and then I'm drawing a blank on the other one now, and also treatment for Regeneron, which is the treatment that President Trump received. Other treatments like convalescent plasma. This latest one is one that I'm going to butcher the pronunciation of. I'm going to say it anyway. Bamlanivimab is the latest one. It is a promising new treatment. We're working with our partners at Unity Point Health Merida to figure out what's the right way to try to be able to provide that as a treatment for COVID-19. But this idea that one of the things that has been, we've seen progress on has been new treatments the vaccines that appear to be very promising. Another area where we've seen lots of change inside the health system has been in our ability to care for progressively more COVID patients, which is exactly what's unfolding in the community today, in Dane County today. So some of that involves physical modifications to our facilities, something like for COVID-19 patients, whether the physical room that the patient in has positive or negative airflow is important. So our ability to be able to adjust the airflow in patient rooms is one of those things that impacts our ability to care for more COVID patients. So some of it has been flexibility in changing airflows and air handlers. Some of it is around the classification of beds. So we talk about beds inside acute care hospitals generally as being, and it's based on how sick the person is, general care, IMC, which stands for intermediate care, and ICU or critical care. And so being able to take beds that ordinarily would we would care for lower acuity patients to be able and equip them to be able to take care of slightly sicker patients has been another one of the adjustments. Improvements and changes in our supply chain. So all kinds of creativity, all kinds of wonderful donations of either stuff, time, or both from partners in the community, some of whom are participating on the call. We learned how to make our own hand sanitizer. We worked with the school to figure out how to create fasteners for some of our PAPRs, the powered air purifying respirators. So developing in-house testing capabilities. I mentioned a little bit about the big push to develop telehealth capabilities. And then more recently, some of our drive-through flu clinics and also the patient and employee testing centers. Telehealth may be one of the longest lasting changes that stays with us post-pandemic. And to give you some sense of the magnitude of the change here, so pre-pandemic, UW Health was doing about 50 telehealth visits a day. We do now about 1,500 telehealth visits a day. Depending on the week, as much as 25% of all provider encounters happen via telehealth, and that was less than 1% pre-pandemic. So what we found is that it is generally a patient satisfier for the providers that are having a big part of their practice involved with telehealth. There was a learning curve in getting comfortable with the tools and the approach, but in general, most folks have found it to be a productivity enhancer and also a patient satisfier. All right, so here's the place where I should have had 20 asterisks. So I'm going to give you my thoughts about what I think the road ahead looks like for us here in Dane County. To talk a little bit about today, so I think we've got a little under 8,000 new COVID patients in the state of Wisconsin. The number in the South Central region, I think, is a little over 1,200. In Dane County, well, this is as of yesterday, on the 18th, we had a little over 500. So the progression and the numbers that I really focus on are positive patients, so new cases, hospitalizations, and then deaths. And those things tend to be connected to each other. So we still are seeing very high levels of new positive cases. The number of hospitalizations, that second number that I talked about, statewide, 215 new patients a day on average. In South Central Wisconsin, that number is 35.5 new patients a day are in our hospitals. And then here in Dane County, it's about 10.1 per day. I don't know if we'll get there today, but this week we'll probably have 200 COVID positive inpatients inside of Dane County specifically. So increases in COVID transmission, hospitalizations, and unfortunately deaths. Based on the data that we have looked at internally, my suspicion is we'll hit our peak in Wisconsin in early to mid-January. So the next several weeks will be very difficult. will be very challenging. That balancing that I described that's going on in hospitals in Dane County, in Wisconsin, and all over the country, with controlling inpatients, the inpatient census, to try to create that capacity for COVID patients. That dance, that two-step, will continue with increasing intensity and importance. That brings pressure on healthcare systems and their capacity and their capabilities. There's a question mark around the consistency, the effectiveness of social mitigation tactics like stay-at-home orders, using good hand hygiene, wearing masks, social distancing. And then also there's a big question around the timing of some of the very promising vaccines, their efficacy, and the production. So I really do, based on what I see so far, the efficacy looks great. I think in terms of timing, we might see emergency use authorizations as soon as the next several weeks. The big issue will be ramping up production, and then the distribution network. How quickly can we as a country get vaccines to people in the community on a large scale? So a couple of highlights from headlines to try to emphasize some of the things that I'm suggesting to you. So Wisconsin is on the brink of a major outbreak. That's dated September the 26th. The unfortunate title of Wisconsin shattering records for COVID-19 hospitalizations, that has occurred several different times. So we continue to see increases, and we're not at our peak yet, I don't think. Promising vaccines. So the Moderna COVID-19 vaccine, as well as the Pfizer vaccine and our AstraZeneca trial. All right, so the Pfizer and Moderna vaccines have received a lot of news coverage lately. The preliminary information looks like they're both very, very effective. The emergency use authorization, I do expect to be quick. And this is, again, my crystal ball, which is frequently fuzzy. I think in the next several days or weeks. The logistics of vaccine distribution, we are working with Public Health Dane County, St. Mary's, Union Point Health Mayor to try to coordinate when we do have vaccines, how will we as a healthcare network, a provider network, be able to participate in getting that vaccine to the right folks in the community. It is noteworthy that the production curve for vaccines looks like this. So in the early stages of production, the thought is that the focus will be in getting vaccines to the people that are involved in direct care of COVID patients. So while the numbers of vaccines are small in production, the distribution plan is for the people that are working on COVID units and in inpatient settings and providing direct care, and therefore at the highest risk, that we would try to get vaccine to those people first. Trying to take care of the caregivers is another area that has been really, really important and a focus of ours. So for all of the folks that have been involved in providing patient care for the last 8 to 9 months, how do you care for them? The stress, the anxiety, what is it that we can do as a health system and as a community to try to provide support and options for relieving stress and helping people to cope and thrive and to continue to be able to provide remarkable care has been one of the things that we've devoted energy and resources to. In closing, I want to make a couple of comments. So one is that the community's response to COVID-19, the healthcare systems are just a part of it. So for each individual participant that has joined us this morning, everyone plays a part in the mitigation tactics. Everyone has the ability to impact our trajectory and ultimately our outcome. The choices that we make as individuals, they do matter. We see that very clearly through contract tracing. So the individual decisions about minimizing travel and staying at home and social distancing and all that stuff, it works. I mean, the evidence is very compelling. The people that are working in the hospitals in Dane County are grateful. So this is a cool place. So I moved up here from South Carolina, and Jason kind of alluded to, me spending some time down south. One of the things that attracted me to the Dane County area, cheese curds, hippies, and cool people, right? So the folks here, the warmth, the kind of not-for-profit, community-oriented spirit is one of the strengths at UW Health, at Unity Point Health Merida, at St. Mary's in Dane County, and here. And that has really shown throughout the course of the pandemic, and I wanted to just acknowledge that. I do think it is possible for us to make safe choices and also to support businesses. So I think the evidence from other countries around how is it that you're able to control or mitigate the spread of COVID-19 and also have critical economic activity continue, I do think it's possible. It does require us to make some sacrifices, though. I appreciate the nimbleness and the creativity in the business community here in Dane County. The support that you guys have shown our frontline staff has been absolutely amazing. And for the sacrifices that each of you and your companies, your organizations have made to try to save lives, I want to thank you. All right, so my hope is that I did not go way over time, and I will try to field questions.
Well, Rick, we cannot thank you enough for the very important presentation. And I want to make sure to start off with that, the entire DMI community and the entire community downtown is so thankful for all of the work that everyone at UW Health and all of our healthcare workers throughout our community are doing right now. To the administrators, to you, to Dr. Kaplan, to our good friends, Julie Olick and Shiva Badar, thank you for your communication, your leadership, the hours that you put in. Thank you so much to the nurses, to the doctors, to the operating staff, the people that I know working in hospitality that park the cars, that clean the room, make sure that all those details are happening. They're putting their own lives at risk. And so we're very, very thankful for everything that you guys have done us to make sure that we stay healthy. Thank you so much for what you've done. I want to make sure to say that. And I want to say a personal thanks for your positivity. This is a difficult time, but I just had this notion in my head when you were talking about Doc Hollywood and you two leaving one of your command sessions on a motorcycle with maybe a sidecar. And I was trying to figure out who was going to be in the sidecar and who was going to be driving the motorcycle. And that maybe it was you in the sidecar with your mullet, your farewell tour for your mullet flowing out your back helmet. So I really, truly want to say thank you for your positivity. I think this might now means more now than ever. So thank you. We've got time for question and answer here. If you have a question, please submit it in the Q&A function. We've got about 6-7 minutes worth of questions. We've already got a couple of quick questions coming in. I think one of the first questions we have is about business you talked about and how businesses can be innovative to make sure that they have that equilibrium between keeping everybody healthy, which they really want to do, their doors open. Are there ways that businesses can remain innovative so that they can remain open, but yet keep everyone safe and healthy, including their employees?
Yeah, so I think, from my standpoint, the things that have been demonstrated to work with mitigating the spread, if we are diligent and consistent about those things. So we look at the physical environment where we're conducting business, and we try to maintain appropriate spacing. We're consistently wearing masks, right? A mask is not a mask is not a mask. So what we're learning is that the face coverings versus barrier masks this is a barrier mask. It's like a medical looking mask. Barrier masks are more effective. The things that I think is least effective are like the bandanas that you pull up over your face. So if you say, all right, we want to use barrier masks, we're going to have appropriate spacing, we're going to be consistent with people that come into the work environment doing that, if we're doing those things, our ability to be able to conduct business successfully improves, I think, significantly.
The next question we have here is about the regional health system. Something that we heard a few months ago that really struck me is how important the Madison region is, not just to Dane County, but to the 7, 8, 9, 10 county region, right? Because of the amazing importance of UW Hospital and the other hospitals in the region. How are the regional hospitals and the regional health system, how are they working together to make sure that everyone throughout our region has the healthcare that they need right now?
Several different ways. So, I'll talk about, let me try to highlight maybe three of them. So the HIC structure is really the key to it. So the first way that we connect to Swedish American, St. Mary's, Unity Point Health, Meriter, is through the incident command structure and those identified officers, and one of them are external liaisons or governmental affairs officers. So one way that we connect is via the external affairs or liaison function. And we have direct lines into other people's incident commands. If we need to talk about something that's impacting all of us, we're able to huddle and to do that fairly quickly. A second way we have been able to do it through COVID-19 is at the state level with participation and representation at the state emergency management group. So we've had Julie, Shiva, Dr. Jonathan Jaffery, and others have rotated in participating at the state EMC level and have been able to try to coordinate our activities there. The other way that we've connected is through good working relationships. So Dane County is really, in my experience, different from a lot of markets when it comes to collaboration amongst healthcare providers. There have been places that it was like the Hatfields and the McCoys that I've worked in, and it's just not that kind of vibe here. So Kyle Norndorf, Damon Boatwright, others at St. Mary's are great. We are partners, we are allies, there are no enemies here. And if we are experiencing challenges related to COVID-19, we talk. And, I'm trying to think. So there was one call Friday, there was another one yesterday. So probably a couple of times a week, we talk to each other about what's going on in the hospitals, how can we better respond and meet the needs of the community. So in at least those three different ways, we try to coordinate the activities amongst the hospital community.
I think last question, very importantly, is how can we as a community support UW Health right now, support the healthcare industry, the healthcare workers in the system right now while you're going through this pandemic?
My suggestion is it begins at the beginning. So when I talked about those key metrics that I look at to try to understand what to prepare for inside the hospitals, new positive cases is the catalyst. And so the positive cases leads to hospitalizations and unfortunately leads to deaths. And so it's beginning and blunting that number of new positive cases that I think is everyone's opportunity to really help the healthcare delivery network here in Dane County and statewide. And it feels, we talk about it so much as a society and as a community, it begins, I think, maybe to get diluted a little bit, but it's not going someplace where you don't have to go. It's, washing your hands. It's those things that stop new positive cases. Things that we've also, been incredibly grateful for, and I want to continue to encourage, so people will donate equipment or supplies. And that has been tremendously helpful. The picture with our supply chain has improved. So the need is not quite as intense as it was earlier on in the pandemic, but I'm at a point where you can't have too many barrier masks. So those things we go through in the hundreds and the thousands as healthcare systems. And so, donations of supplies, thoughts and prayers are a big deal. And to the extent that people are able to have signs or thank someone in a safe way that is an essential team member, saying thank you to someone that goes to work scared every day to care for COVID patients, it impacts people in ways that you don't know. So, you can't hug a frontline team member these days, but thank them and show your gratitude.
Well, I think empathy and humility are a great way to get through so much, and with positivity. Rick, we are so thankful for your empathy, your humility, your positivity, and your very important presentation today. Thank you to all of your colleagues at UW Health and UW Hospital. Thank you for all you're doing to make sure that we remain safe. We really do appreciate the comments today. A quick note and a thank you to all of our sponsors here today, to Whipley, to Ho Chunk Gaming Madison, Michael, Best, and Friedrich, the State Bank of Cross Plains, our sponsor for today, the Capital Bank, and the Edgewater Hotel. Please support local businesses now more than ever in safe ways like the Edgewater Hotel. And of course, our friends at UW Health, Unity Point Health, and Meritor Courts. We are very thankful for everything. We hope that everyone has a great rest of the day. Hope everyone has a safe and a relaxed period and over Thanksgiving. Thank you all very much for joining us. We will see you again soon, and stay healthy. Have a great day.
Take care all.